Hello to everyone. Thank you for your presence. We're going to be talking about prescriptions controlled or with the help of artificial intelligence. The relevance in this area, prescription controlled by AI, is really such a long story since we've had medication, and this situation has accentuated the problem. It's more difficult now to have a prescription that is optimized. Today, we have technologies that are different, and I think there's really no player who really knows what he spends for the different prescriptions. So artificial intelligence is now present. So my first question will be for Marguerite CAZENEUVE, specifically concerning artificial intelligence, especially in the area of prescription controlled by AI. Maybe we'll talk about diagnosis as well. Is the health insurance? Do you have a plan? Yes, we do have plans. That's by principle. What we need to say is that today, artificial intelligence and innovation, thanks to artificial intelligence, is really financed and disseminated quite greatly. So the appropriation by the system and its financing is being actually raised, and in critical terms. So the most impressive example is when we have diabetic patients, because today you have systems of the closed loops. And so these are medical individualized dispositions based on their ages. And you have the artificial intelligence. You have this algorithm which is plugged into this situation. And for the different reader, and because of the HSS, who's made this evaluations possible, now we have a prescription. And what you see, go beyond the prescription, we even have the delivery of it, which is controlled by artificial intelligence. This is the medical dispositions for patients. And we will see also what the most we have with the question, which is the different professional equipment. So the diagnosis, for example, and everything in imaging, because the question of equipment, professional ones, is largely we don't have any evaluations. The HAS is not competent in this area. And so it results that we have commercial relationships between the professionals in the health area and industrialists. And without any evaluation, it's difficult for us to know where we need to invest so that these prescriptions and these equipment will be relevant in the health area. Yes, so now I'm going to go to Franck after, but the evaluation is very important for each healthcare systems, and because we know how to evaluate medication, and also we're not as rigorous in other areas, but everything was artificial intelligence and digital technology. We don't really know if the criteria should be the same as for medication. So we don't know what should be the doctrine related to this. I think it's, well, yes, the subjects, we have two different kinds of medical devices. We have those are for individual use for the patient, and this is really the French structured situation. Just like for medication, you have this evaluation process, so that once we have the HSS has pronounced it, then we have the prices that are fixed in the medical devices for the patients. ALIA is correctly evaluated and inputted. I think it's in this area we don't have much to talk about. However, the real question for industrialists is really those who have really succeeded in the area of diabetes because they had 10 years of data. And so the question for them for reimbursement will be the data, because these are new entries, and the health insurance will be reimbursing the healthcare. It's not the health care insurance that will be handling the collection of the data, and this is where we'll have a challenge. Now you have these medical devices, which are collective ones. So this is equipment for professionals in the health area, and today it's really the same in robotics, imaging. It's really here we don't have any HAS evaluation. So really, you're in a relationship, which is a commercial relationship between a professional, an establishment, and an industrialist. So this is where the distinction, when you have the individual one, or you have the equipment for the professionals. So we'll be talking more about the evaluation, because I think it's a very important subject. Frank, would you like to add something? Would you like to react to that? And does that seem to you compatible with what you know in your professional area? Yes, I was saying that in preparing this roundtable, the title, in fact, I was really thinking about and now what Margaret has said concerning the different medical devices, and it's not Marguerite who made the title. Well, in any case, I think Guy, don't blacklist me forever, Guy, because I will continue, and I will transform the word control by propose. I think artificial intelligence is part of our daily lives, and also chat GTP has also done a lot, and will be part of chat boxes clearly entering into our daily life. It will be considerably modifying our professions. And Marguerite, we have to talk about this because it's going to be modifying the financial aspect of our professions. I was talking about Guy. Guy, in this interview about this subject, he was saying, and I do think this is really good for the doctors, and it's also good for the patients, and also for the users. We don't have enough time. We don't have enough doctors. And we're not lying. We're lying to our citizens. We're not saying it's a worldwide problem. We don't tell our citizens that there are things that everybody can understand, that the world population in 2 generations has been twofold. So now we are 9 billion. So in 3 generations in France, we had 20 extra life expectancy years, so more aged persons, so more chronic diseases. So it modifies the doctor's profession. And so there's less medical time. So I think it's very important to tell them that. And behind that, you have to come up with the solutions. And solutions, it seems to me, are this natural evolution. And also, we can think of how the contribution from artificial intelligence. The doctor said to be experts in the treatment. And so this is what we heard this morning, as you were talking about the ski. So tomorrow, the doctor's profession will be different because you will have the one who he will be distributing the aspects. So the family doctor will have this profession. He'll be distributing. He will be playing like a soloist. But you have all the specialists and all the other professionals in the medical field. So artificial intelligence will really make a great contribution. And obviously, it will simplify things, and it will give us more medical time. Artificial intelligence will be able to apprehend this medical knowledge. In fact, I'm a little bit older than you. We do the same specialty, but I do remember when I was a young intern a few years ago that we were saying the medical knowledge that takes 5-10 years, but the last data said every 62 days the biologic knowledge is multiplied twofold. So, in fact, that doesn't mean the brain will work better, but however, we do now absolutely need to have this evolution. When I say let's talk about, yes, because that requires a modification, an in-depth one, of our organization, the way that we will be having, promoting added value. And that will be, and I think it's really good for the society. I'm not advocating something, but I do think it will be changing things. There's really a long debate. But anyway, let's stay on the topic. I want to, if you could say, what is the position of the different complementary actors in this area? Have you already have an idea about that? Are there different initiatives that are in parallel? Or will you have partnerships with the health insurance fund? I will go back with the health insurance fund in partnership. Yes, we need to talk about partners. I want to go back over. Can we criticize the title? I would have preferred that the title of this roundtable be relevance and quality of the health care plan for a patient. So I do not want to restrict the subject to just a very short, precise time. So you can restrict to an act, a medical act, but I talk about Malakoff, Humanis. We're a complementary actor to the social security healthcare system. We feel that we have a role to play in the performance of the system through our role, and also the relationship that we have with our insured clients. And these are persons, normal persons who live and work normally. And so there are different opportunities to roll out policies and solutions which are of interest to have better understanding. And for the healthcare system, this is something what we want to work on. We want to be able to do this in a more efficient way in partnership with the obligatory regime. Now, also, I cannot conceive AI alone. So I put digital, I added data, and so IA is intelligence, digital is connectivity, and the abolition of distance, etc., and data. This is really what should be shared even more today, especially at the different levels, and not just between doctors. And so, just in a nutshell, when I think of IA like that, then I do think, and I completely changed what I was planning on saying. I was listening to the different roundtables, and I said, it's not possible. 10, 20 years, that Guy has already said this, we know what we need to do. And we're adding these improvement elements in this system that is structured, but it's not moving. Separation of the hospital, do this and do that, absence of really treating the patient and involving the patient in diagnosis and having it more personalized. So what I think is that AI, associated with digital and data, that creates and enables us to really think out of the box and how you can handle patients, and also to get rid of this silo, this situation where you have just illness doctors. So I think prevention and the whole healthcare for a whole life, if it's just in isolation, you think of health in isolation, it's not going to work. You have to have an environmental ecosystem to have special plans, healthcare plans, and that's what we try to do. And this will enable us to really have a long-term approach. So health is not just when I meet my doctors, when I have the opportunity of seeing my doctor, but it's really an everyday health care. So intelligent artificial, in fact, directly, can you tell us what you and your complementary health insurance schemes, what is their positioning? Well, can you talk from your own position? Yes, I can talk about from my own structure's perspective. The complementary health insurance, they can do things, but they also have to have a very good system that is not in existence today. We'll be talking in more detail when we talk about our models. What are we trying to do? Simply, we have this relationship with our clients. Just you can have other social and different health insurance they have this relationship. We have a double kind of channel for our different patients. We have one with our patients, also with the employers of our insured, with our clients, and they are very much interested in really having health in their companies. And this is not the subject of the roundtable, but we do have companies that really today they want to have practical tools so that their staff are not sick as often, or they are handled better when they do have health issues. What we're trying to do, simply speaking, is to set up solutions that will be capturing data from the persons. They will have an artificial intelligence, either based on medical expertise, and they will position the patient in a certain profile, and that way we can orientate them to their practitioner so that they can have adapted healthcare situation. And my dream is that practitioner can actually have the profiling of the patient, because it's not just you're not just going to see this patient just because we are addressing him to you. No, we want it to be a different kind of approach. We want to see, because we have this element, this subject, and this, if he knows what is the interest, thanks to IAA and digital technology, we have pre-diagnosed or retargeted the situation, and predetermined is the way I'd rather put it. We have predetermined the interest area. For example, there's suspicion of diabetes, suspicion of risk of a cardiovascular problem, etc. These are the kinds of things that we're working on today in an operational fashion. We're in experimentation in this area. We have some 10,000 people in our trials, so that are just are part of this experimentation. Once we've done that, we've orientated our insured person. We have given the doctor, if possible, complementary elements, and then we want to support them in the insured in their healthcare. And when we have a system like this is a digital system. So physical, we put human in there, so we call it physical digital. We include in the design the system that will enable us to have an evaluation, which is for the usage, the impact, and also the effective healthcare plan for that insured person. It's a fantastic opportunity. But today we're so occupied by the different actual structures. So we have to rethink the organization of healthcare, etc. But we have to abstract it in the first time. We talk about the patient and his daily life, so we can propose something. Thank you so much. Emmanuel, would you like to talk to us about your solution, which is part of the roundtable? I do like the roundtable's title. Thank you. Well, we are a startup, Posos. It's called Posos. We're not CNAM. We are very, very concrete, concerning specific issues. The doctors today, we ask them to be available, but they really are overloaded. We want to be more available. They can see more patients. We can have access to health that we want to maintain. But however, they're saturated. So once we've been asking since the morning is that we can have relevance, quality of healthcare, and infallible. So the doctors have to work quicker, they have to be available, and they have to be infallible. They cannot make a mistake, infallible. So this is what we want to do at Posos, is that alone, if a doctor is not assisted, he cannot handle this. So if he has a digital technology, we have a tool that Posos has constructed. So for the healthcare, number one, what's most important? This gives less this time-consuming activities, so he has more time. And we have information that we collect when we go to the hospital. The anesthetist will be in 5 minutes. We'll know the whole have information from the software. So they will have all information of the software. At Posos, we enable to automate this information. You take your mobile phone, you take pictures of all the prescription. Everything is in the software. And so we gained a lot of time. And so this is the next effect is that we can guarantee the doctor of not missing out of different kinds of medication-related risk. So we have to guarantee that each of the medications is compatible with other medications. He has to guarantee that each medication is compatible with the profile of the patient, which he can be diabetic, he can have kidney issue. We have to make sure that posology is adapted to the subject. When you have 10 different medication to ingest, it's impossible. So in fact, usually it takes 30 minutes to do this kind of review of medication, but it's impossible to do that. But with Posos, this can be done in 5 seconds with this technology. And so there's an alert, a risk. We know all the different risks. This is where the doctors can propose a more appropriate medication, which is compatible with the profile. So we make sure that the patient that goes from a hospital, pharmacy, or medical cabinet, he doesn't have any medication risks not corrected by the doctor. It's important that what we've said, you have productivity and also quality and relevance. Is this typically a solution which could be supported? And since we were saying earlier, the evaluation is not mature, so how can we have the solution, not just this one, how can it really show a real clinical benefit, and even at the whole level of the population? This is where it's really interesting, because typically we are looking for a solution which is not just for an individual patient, but for a professional. So we go into this really vague area, which is like where we have industrials and the relationship with industrials and professionals have different relationships, and you have arguments with productivity is one issue we spoke about, and the comfort of the professionals, we spoke about this as well, and the quality, and to be infallible. And so normally these 3 different arguments are to convince the buyer, the professional of health, to acquire these tools. And we, in our health insurance, we want to say, we pay for this service because we have this technical lump sum budgeted. So we come, and we're at the last step in the last recourse, where you have where the tariffication of the doctors is actually planned for. So professionals, we have this an added value. What you do is good. Yes, Monsieur. So you bought this, so you DEVULDER, you could gain this in comfort and also quality for your patients. Where it becomes more complicated is all these devices that are destined for the doctors and the establishments, when in reality, they have to have externalization for the whole system. They have impact. So in other words, you can reduce the rehospitalization. I sell this, so I go to the hospital and say, look, thanks to me, this hospitalization stays can be more organized, and so the establishment has not going to be. It's not going to be gaining in a strict point of view, but for the health system and the health insurance, it's clear that this is a positive externalization, is positive for the patient. So this is where we have this gray area in financing. And so there's two questions that this raises. We have to be able to identify with industrialists and with the professionals where, in a certain way, the law of the market in a strict way, where it's not functioning, we have to intervene. And these are where we have to identify a lot these healthcare plans and it's in their journeys. And this is really interesting for this roundtable talk about that. For me, it's the specifications that we have to co-build together. And this raises a second question, which is more the principle of the evaluation of all these equipment for the professionals, because in the end result, you have a fantastic device because it's fantastic. It will be bought, and then because it is relevant and the health insurance is normal, that we would pay the professional at a certain level for this. So imaging, we have 60% of the softwares that come with these links would have never been evaluated by peers, and so the professionals, they buy material, some ultra-performing and others not at all, and at the end, certain manner, we pay the bill. So this is a problem. We're paying this in a blind way. So when you have super innovations, organizational and others for health professionals, it's also where you would need an evaluation from the HAS, who say this innovation, it really changes the lives of the doctors, the patients, and also for their health care. And this money, we will budget it. We will be part of the different allocations for the health insurance. But right now, we're a little bit going through this blindly. I want to react because you have this situation. We talk about evaluation. There's another thing. A lot of these solutions today, they come up from startups. And Emmanuel, he raises money, and so you have the timing, which is very important for the startups more than for the big groups. It's not that the big groups pay, but the startups, they are subject to this. And I was talking yesterday with the director of a counseling firm. It's difficult. We say our startups better to go abroad because things go quicker. I'm not saying things should go that way, but how do you think, how can things go quicker if you have this acceleration of reimbursement, for example, if the solution is not keeping its promise? So it's I'm a little bit reluctant. Have some reservations because the French market is small. When you go to the U.S., you have integrated groups. So when you sell your solution, you have this critical mass. So the market is very of interest. So for us, we have this normative interoperability rules that are being questioned and are at question here. So how can we make things go quicker for these companies so they can do business? Now, concerning the patient part, maybe the industrialist will contradict me, but things go very quickly. In 2020, the HAS came up with this special link, and so all these different ones that went to the patients were reimbursed. We had lots of different devices because this is very regulated in the French system. You have lots of ways of taking shortcuts and going quicker, and we have special lump sums for innovation. We have a lot of different measures that enable us to go quicker now for all the different startups that develop solutions for professionals. In fact, we at Health Insurance, we're not in that game, because it's not just a question of reimbursement, it's a B2B relationship. And in that case, you sell a service, and as the service has value, well, then the person that is the person involved will be buying it, and we're not involved in terms of valuation and financing. Franck, do you think that the doctors should pay for these kinds of solutions like Emmanuel, or do you expect to have support from the health insurance? Of course, they are supporting a lot. Well, this is the time and proof approach, which is how things are working today. It's true. You have the time for proof, and also the acceptance of innovation, and how can we have access to this innovation? How can this innovation enable us to have better access to health care, and how can we finance it? And even though Margaret might not be happy about this, but it's not with the tariffs today that will enable the doctors to innovate and to make bets on certain innovations. I don't think the health insurance should be doing that kind of work, but how the time of proof enables a certain time. Maybe even if we go quickly, we don't know in all different areas, the pharmaceutical studies about medication, that takes time, surgical and technical areas, it takes time. You can't just do it like snapping your fingers. There's urgency, because our citizens today cannot find access to a doctor in an easy way, and it takes too much time. It's going to get worse. The Ministry of Health says it's going to be 7 or 8 years, or maybe even 20, 30 years. When you look at the CHAM reports, we see that there's the situation will be will worsen. And so, but there is agility, though. We are ways of getting agility. So we have to take maybe co-financing and different finances, maybe a doctor when he can, complementary insurance as well. We have to open up these new areas that we did not want to open this up, since we've had health insurance for 40 years ago that were started up. You're talking about the prescription of medicine, that maybe it's basically direct with the practitioner, who either he wants to do his job really well or he wants to improve his economic equation, then he'll be involved in this. So these medical prescriptions, like in all countries, it's not perfect. And you have prescriptions that could actually are not necessary, have maybe hospitalization because of different kinds of complications. So health insurance also is interested that these solutions are massively rolled out in a market which is, of course, imperfect in areas not just the healthcare. I think it's very interesting, because it's really interesting because with the three elements that are of interest for the professionals, you can have a checklist. There's also positive externals that we have to take into account. Everything which is, we can give this example, prescription, limitation, have the fair, just prescription. We have the different rules concerning the right dosage. And this is part of the solutions in which we can say either we will have a direct financing with different tendering, because we say this is really here where we have to go, or otherwise we have this conventional relationship with doctors. We say to the doctors today, a generalist, prescribes 750,000 euros of prescription each year. So, okay, different devices and medication, and the medication is 50% of the carbon impact on the health system. And so, for the different reasons, this is ecological and different economic impacts. We consume medication and it's overprescribed. If we could have mechanisms that are intelligent, that are relevant for prescriptions, so that for the delivery, for the health authorities, this will be another way that we can modify the budget envelopes. We'll put less money in the medications so we could really put added value on the health professionals. But this means we have to find a contractual system where not to be at the detriment of the patients, but to say just to have the right prescription. We are ready to finance this directly to the doctors, and it's a deal, win-win. So what kinds of indicators would you retain? This is where we would have to really look at that, look at the number of prescriptions, the percentage of prescriptions that are followed up by medication delivery. A consultation. So you have so I think 75%, and in Germany it's 20% for these prescriptions that are, so if they're followed by medication, this can be an issue. And so when we look at the different gaps in the distribution of the health professionals in the prescription of medications, we have lots of gaps. So maybe we have to place added value once we have standardized patients and correct the different size issues, made adjustments for that. Then we should encourage a bonus for professionals so they could be orientated in being more having a sober approach. It's not just the medication, it's also they could stress prevent, they can also give special education concerning physical activities, other areas, diet, etc. They can do other things that we can place value on those other areas, and those we can have like a contract with the doctors. I also would defend this position because for a startup, we support the supplementary step, because for Posos, the Ministry of Health has also financed a very important study with 12 hospitals, 100 different investigating doctors, we have Posos and non-Posos, and we can see that the Posos, they have more prescriptions that are more just and fair than those of the non-Posos. Once we'll have the study being published, we will be able to relaunch this debate once we have the study. It's not just a volume of prescriptions say we're going to get rid of one medication. It's really to have the right prescription. That's what's really at stake. And to talk about what we had the roundtable with Airbus at the level of Europe, the side effects concerning them is so 200,000 deaths every year because of prescription errors, because the doctors don't have 30 minutes to control everything. So 50% of them could just be handled by a check. So we look at the impact in France. If every medicine had a tool like this to prescribe, I think that we would really be in a massive area. But we have to prove this, and this is where we're supported. So the next step will be important to talk about that. Yes, the medication and over-medication, and the health insurance has published a lot about this area. It's really is a very important issue, independent of other topics. So this is the right prescription is what is important. So less than more is better. So it seems to be obvious. We can't go against that. Simply, there's a red line. We have to distinguish between the relevance and what would really play an important role, and the efficacy concerning the right use based on the scientific proofs, HAS or other, and the efficacy. Also, what's important is the counting area, and not just medical issues are important. We can't talk about diagnosis; we don't have time. But there, we are both gastroenterologists, and we are at the end of my. When I was at the head of my special days in Paris, where we would be confronting the different screening methods with our European peers, because Invicus professor for the University of Amsterdam was saying, how many endoscopies do you do in France? You do how many? Well, we don't know, because no one knows. And so 1,400,000. So quality is very important. So health professionals today, and we know this, they are the ones that took this initiative based on quality criteria and relevance, which are absolutely infallible and perfectly proven scientifically, to improve in their practices. And based on this economy, you have to midterm approach. Because with this financing year after year, we cannot prove this. However, this virtuous circle is possible. There is a red line. What is the red line? It's not a dry accounting, economical issue. No, never. Health is not like that. We defend the insured. Yes, I'm certain you do defend the insured. I think there is a subject that is specifically French, a real difficulty to roll out innovation, either with artificial intelligence or others, and because of this rigid economic model. And it's really because we have a very rigid, fixed economic situation. We're still in the 20%. We're not interested in the 80% of the improvement processes, which are not in the organization, but they're in the different potential areas that we can open up with the artificial intelligence opportunities. Today, and Margaret was saying this, if we have a medicine, we have process to the market with ADM that really exists. When we're other things, when we are really new, innovative, different, then we don't have this access to market process, and there's really a problem for market access for the startups. They come to see me, and they say well, we don't have the medical capacity, cannot really give us much financing, and just for very low budgets for experimentation. And we do see that these small startups have problems. There is this ecosystem, which is the ecosystem that's very developed, and there's a real weakness for the capacity of financing in a long-term approach services. We were talking about potential partnerships with health insurance. Do you have hypotheses? Should it be we take X percent or 80%, or we split it up one third? Yes, this is why we proposed to co-finance prevention, but it wasn't possible. But we want to co-steer this program of the special dental generation program, and this is really good. When we talk of the Article 51, there was this, we have systems that are completely innovative health, which we are really waiving all these present ways of operating. So we do have this common law, so we can have experimentation based on this 51. But this will be lots of difficult regulations related to this. However, what I ask is so that we can work together. So what is the right way of financing so that we can finance these innovations so that they can develop in the market, because they do exist, but it's difficult for them to exist. Once again, concerning technological innovations, I would like to repeat, the health insurance, 99% of the startups say, can I finance them? But that's not our job to finance startups. It's not your job either. The subject in France is to have an evaluation system by scientists, by this third party. We are not the evaluators and this third party. So we need to have a scientific evaluation by the peer, and based on these scientific evaluations, then there you have this relationship. You have this reimbursement integration with the acts, and we at the health insurance, we as financiers, we execute the decisions that come from the lawmakers. They come from the scientific committees based on evaluations. We don't decide to finance X, Y, and Z. And just to finish, how much is the budget for health insurance today? Can you tell us about that? I could not say that figure because with the, you have, it's very difficult because it's embedded with imaging. So it's difficult to give you a figure about the relationship and the amount with the artificial intelligence contribution. Thank you very much for listening.